seems to work. So I was given the kind of open-ended task of talking about research in mHealth. And I didn't really want to give a research talk because I imagined that would be terribly boring this time of day. So I'm going to talk a little more sort of high level about where I sort of see some of the big sort of splits in what we're thinking about research in health. So I start with some humorous aphorisms. So let's start with this. Really, the story, in some ways, behind this class is mobile EDC. And so, do you guys know what that is? Anybody? Electronic data capture. Very good. So, this is good because otherwise we're really getting into trouble early on in this talk. So yes, electronic data capture, and so a number of years ago, I'd just come back to BU and was interested in electronic data capture, and had come across OpenDataKit, Googling around one day, and said, "Gee, this looks really interesting." And I said, "Let's do a project," and advertised for students. And then Marianne and Laura walked in the door the next day, and that was how we began all of this. And so we spent a year and a half thinking about how to develop an electronic data capture system using cell phones and this software called OpenDataKit, and sort of taught ourselves how to do it and got a little bit smart about it and learned that we didn't really like ODK after all. It was kind of clunky. But we learned a lot by doing this, and then Marianne hatched this idea for teaching a class, and so then it became like an mHealth class, and sort of generalized, and here it is. But for me, it all began with electronic data capture, and I'm still sort of fixated on this because I'm a researcher, and basically what you do in research is you collect information, and if the information is wrong, then it's not useful. And so we spend a lot of time trying to figure out how to get the information quickly and accurately, and electronic data capture has some features to it that are very attractive, and I'm going to talk a bit about that. All right, so let's start with some obvious things. So accurate data matters. Now, so this is the Dirty Harry. You've seen Dirty Harry?
Yes.
So I know what you're thinking. Did he fire 6 shots or only 5? And all this excitement. We have Dirty Harry meeting Rain Man. He says, yes, 6. It was definitely 6. So accurate data clearly matters. And so one of the problems we have in research is that so much of the information we capture is dirty data. And we spend an enormous amount of time cleaning that data. And that process can literally take months or years. So I want to split this discussion into 2 parts. One is talking about the use of mobile electronic data capture as a tool for conducting research, and the second part is actually to talk about mHealth interventions and doing research on mHealth, which are totally different things. Okay, so one is just like we have a cell phone, we're going to do our study and we're going to capture the data on the cell phone, as opposed to many of the things that we've been talking about here, where you have an app on the cell phone like you've developed, and you're going to use the app to force some public health change. So it becomes a tool for public health. And these are very, very, very different concepts, obviously. So I'll talk a little bit about both of them. It's not going to be a talk, it's going to be more of a discussion. So we'll start with the first one. Now, many years ago now, I did this study called the Lithuaniana Neonatal Survival Project. And in this, we were testing the question, can we train Zambian traditional birth attendants to do neonatal resuscitation at a village level for home births, and will that reduce neonatal mortality? And it did, by the way. No, but this was over a huge area, and so we had this entire district mapped out, and we had this team of data collectors on mountain bikes, literally, with rainproof backpacks who would sort of zoom around the district trying to find the birth attendants and trying to find the moms and figure out what happened to the babies, and then filling out all these forms which they put into the waterproof backpacks. And then once a month they would take these forms and they would hand them up to their line manager, and the line manager would presumably look at the form, except that often didn't happen, Instead, the forms would then be transferred up to Calawushi to the central office, and then the data collector, the data entry person would come and type in the data, and then the second data entry person would type in the data again, and then they'd look at the two sets and they'd say, gee, they're not the same, there's an error here somewhere, so then they would sort of reconcile that, and then they would say, well, now they're the same, but this answer doesn't make any sense. Go find the data collector, so they would send it back down the train, they have to find the guy with the mountain bike and the backpack, and it would sort of go back up and down, and it was sort of this yo-yo of information going across this vast distance. And it was terribly inefficient. So the time from like when the data collector's with the mom saying, how is your baby, ma'am, to when the information entered up in the computer and was valid was like months of delay. And so the idea of like having control of the quality of our data collection was impossible. Because by the time that we learned that the data was inaccurate, the study was over for that subject. And finding them again in this vast place was difficult. So this was a sort of an early reminder of how important it is to have early and accurate access to your information, which we definitely could not do with paper. And so this was an important learning point. So I guess I would ask you, so given what I have just described to you, where do you sort of envision that like a paper-based system would have bottlenecks that would sort of slow you down or introduce error? Any thoughts on that? I've mentioned a few. So. Sure. So like where could the inaccuracies come in?
So if it's a handwriting, if you can't read the person's handwriting, and then you have to find the person and ask them, what did you write?
Absolutely. Okay, so difficult to read forms.
Losing forms? Losing forms?
Oh my God, yes. Not only losing them, but having them like literally destroyed by the army ants. So yes, forms getting wet and moldy and rotting away, and then you're like, what does that say between the holes? Yes.
Questions not being answered?
Yes. So how would electronic data capture get around that?
By forcing you to answer.
Yeah. So I really wish we had that, because we had, Laura. Did you guys know Laura Sabin?
Yes.
Okay. So Laura is an economist, delightful. And her job in this was to create a cost-effectiveness analysis for the study. And that required forcing them to go through this long grid of like, how much money do you make, and how many bags of charcoal do you use, and how long does it take you to get the clinic? It was a total nightmare for these people to fill all this information out. And so the data collectors hated this question and would skip it because it was a pain. Okay? So not letting them skip it would have been very helpful. So yes, what else? What else?
I would say time as a whole is a bottleneck, because it just takes so long from the time you're asking the woman to go into his manager or whatever to shipping it off to the administrators.
Absolutely, absolutely. It was slow and painful. Ashley,
that was the same point. The chain of command.
Yeah. I mean, so there were like bottlenecks all up and down the chain, and it's the kind of thing which you don't necessarily anticipate when you're sitting in your Boston office kind of writing this protocol. It looks like it's going to be very seamless. When you try to execute it, it's really a disaster. So, all right. Error. So we talked about where it slows it down, but where do errors occur? Some of them we kind of mentioned, actually. Any other places you can think where mistakes enter the set?
I was just thinking about your story about the economics part, and how the alternative when forced to answer these questions would be perhaps just to enter false
garbage data.
data.
Yeah, absolutely. Fake data. That's happens. What else?
Switching numbers, so instead of like 23, right, 32.
Yeah. Which is the one that's sort of notoriously vulnerable to that? A feature data that gets entered wrong all the time. Dates.
Yeah.
Is that
It's culturally listed.
December 3rd or March 12th? People constantly switch the month and the year, the month and the day of it.
When data is being transferred through multiple hands, like the first person gets data from the mother, the person next person finally gets the pertinent things of the database, and then takes over the data. During that process, there's some loss of information and misinformation.
So where do you, I mean, there are different points where the data can be wrong. For example, I can say to Adam, are you a man or a woman? You'd say,
Clearly a man.
right. So, data collector then writes woman. Okay? That error is unavoidable. Okay, that kind of error is unavoidable. An electronic data capture will not fix that mistake. Nothing can fix that mistake. In research, we talk about the source document. Do you know have you seen this term? Source document verification. It's going back to the original piece of information upon which everything else is based. And beyond that, there is nothing. So it's the original question that says, Adam is a woman. That's the source document. The source document is wrong. Okay? And so no technology will fix the source document being wrong. But what we can do is we can fix the problems afterwards. So that, supposing that Adam said man, and I wrote down man, we got that right. Now it goes to the data entry clerk who writes woman. Okay? So now we've changed the data. And as it turns out, not surprisingly, the vast majority of errors occur at the data entry clerk, going from paper to electronic. 95% of the errors right there. And dual data entry is a way to reduce that. But dual data entry doesn't work very well because if data entry clerk 1 says man, and the second one says woman, then you still got to go back to the source doc, which is back out in rural Lithuania somewhere, and you can't find that person. And so it is not a very good system. So what would be better is to not have data entry clerks at all, beyond the person who creates the source doc. So one of the anxieties, I should say, I've encountered when talking about electronic data capture is that people like to have a piece of paper as the source doc to sort of verify that. But if you think about it, that piece of paper is no more accurate than an electronic source doc. You know, the fact that I wrote down female for Adam, or that I typed in female for Adam, is no different.
But isn't there an issue with reconciliation? If you at least you have two documents and you have something that says one thing and there's a discrepancy with another piece.
You know that one of them's wrong.
You know that one's wrong,
but you don't know which is right.
Right. So if you only have one document and if it's only electronic, how can you tell? Where do you reconcile? At what point, or can you reconcile?
You have to go back to the source doc.
So you'd still end up having to go back.
Yes, but in this case, if you're doing electronically, the electronic doc is the source doc, so there's nowhere to go.
Right.
You're done.
Yeah. Right.
So that's the answer. Even if the answer is wrong, that's still the answer. Because you can't fix the first mistake. You can't fix the first mistake.
So in Kenya, the AMPAT program, they have data entry warehouse for about 50 clinics, I guess. So it's a lot. So they get all the paper forms are sent in, and there's 100 clerks that just do entry, and then they do double data entry, but it's not to. They actually do it about once a week on about 5% of documents on the single day, and it's just to get error rates. And they use it for QI in the data entry process. They don't actually use it to do any form of data correction. But the other thing that they operationalize that I thought was really interesting is they use it as an opportunity to correct the forms. And so forms will come in, and some percentage of them are actually wrong, and they flag it, and they just have it go back with all the good forms, and then the doctor has to fix it, and they send it back again for data entry.
That's ideally what would happen, is that you would send the data entry, the data collector back to the mom and say, is it true that this baby was born on, December 3rd instead of March 12th, because that appears to be in the future. Which would be probably wrong. They said, yes, it's wrong. And you're like, oh, God, I thought so. So that I mean, of course, that's an obvious one, the time travel one.
When because they did try EDC, and they actually, because they removed that correction point, they ended up with lower quality data when they switched, which was an interesting thing that I don't know happened in many places.
We have to think about it.
Yeah.
All right, let me keep moving. Okay. So the second, my sort of second big introduction to electronic data capture and research came when I was working at Novartis. And we were in this mad rush to license our vaccine before Sanofi. And so we'd done all this work for years and years and years. It cost a lot of money, and we'd finished our dossier, and we wanted to file our license application to the FDA immediately. And so the CEO of the company said, okay, we want the BLA to be filed 2 weeks after last subject, last visit. It's impossible. It seems impossible, but it's actually not, because if you do electronic data capture, you're cleaning the data, not at the end of the study, which is what you traditionally do, but from day one. And so by the time you get to last subject, last visit for your 18,000 study subject trial, it doesn't matter, because you've cleaned everybody already, except for the last subject, and it only takes you 2 weeks. So you actually can get to, you can lock the database very quickly, but only if you're using electronic data capture. All right, let me keep moving. So, Wither mobile EDC. So these are clay cell phones made in Darfur. I don't think they work. They might. All right. So let's think about, as a group, brainstorm a bit. What situations can you envision where electronic data capture would be particularly useful? Like problems that could be definitely solved by electronic versus paper capture. So let's just imagine for a second. Then I've created a list too of things that I think, but I want to see what you come up with first.
Well, with the dates, you can have it display the actual month name, but it would record it as a number.
Right, so you avoid the time machine paradox, okay? What else?
Transferring lab results, so you don't have to travel back to the clinic to get.
Oh, right, so you can pull in data from different sources electronically. It's a very good thought. Yes, you can do that. Good.
I'm kind of thinking about like when you're actually getting the data, like in circumstances where a person won't have like sitting down with paper, just being able to sit there and talk to somebody really quick. It just seems less time consuming and informal. Maybe people will be more willing to talk, or like maybe they'll be more willing to give out the data instead of like this whole writing down process.
It's possible, and I'm glad you mentioned that, because the issue of subject data confidentiality is always kind of huge in research. And one of the concerns that comes up with later electronic data captures are these systems robust against hackers, is the data safe. And I was reminded of an event where one of our study coordinators on one of our trials, which had a lot of subjects with HIV in it, left her bag filled with old forms, the consent forms and the baseline data forms in her car. The car was broken into, and they stole the car, along with all the forms. And I'm sort of like, okay, there you go. For example, paper forms are not exactly robust against theft and confidentiality, because now you've got all these people's names and their HIV status written on the next piece of paper. I mean, it was a disaster. Fortunately, they found them stuffed into a sewer the next day. So the thieves didn't want the study forms, they wanted the laptop. So, whereas with electronic data capture, you can encrypt them on the device, so if they steal the device, well, so what? They can't get the files. It doesn't matter. And then the transfer of files electronically, sure, I'm sure there's some brilliant hackers in North Korea who can get into them, but why do they want to? There's no money. So actually, the safety of electronic files is far better than paper files. Okay. What else? What other? Hands up all over the place. You and then you and then you.
Okay. Calling for the lab results, if the lab tests themselves samples, if you can take pictures of them and upload them to a central lab so they can read them and bring the results immediately, especially in cases like malaria or something like that.
Very good point.
Instead of sending a set of samples to the lab.
This is kind of going off of that topic about people maybe being more willing to share information. I think in one of my other classes last semester, they were talking about how, kind of like a voodoo idea, or as soon as in a culture, in a community, they think oh, this is bad because it's coming from the new world and they don't want to share things. So I think there's a difference between, I personally think that the electronic things are better, but I think there's a potential for bringing out a phone and putting things into that for anyone, even though we know it's going to be restricted, the idea could spread quickly that anyone can now see that information because it's in the phone, because they understand the sharing calls and
so
text
there's a
messages.
perception thing that you have to
You have to address it, yeah.
Very, very
Just
good.
on that, I think it goes both ways though too. Sometimes, from the work that we've been doing with Comcare, sometimes they feel like it's more trusted information, and that but that whole idea of patient privacy and privacy of data is really interesting. I think
Yeah, I think the
we both-
perceptions just have to be addressed in the right way.
Or sometimes it makes the data collector look more professional.
Yeah, exactly. That's what I'm saying. Like it's more professional, but then it could be a fear too.
I was going to say putting conditions on the data so you can't enter, they're 8 feet tall instead of whatever. But what you're talking about, the pictures of the prescriptions tracking fake prescriptions, I know they're doing that now with the scanners on the prescription, so you can see if your prescriptions actually came from a valid source.
That's good.
That's
So,
a way better one.
Are you referring to like the radio frequency IDs that go into the pallets? Like a lot of the pharmaceutical companies do that. They'll have
like an RFID scanner or a barcode
scanner.
scanner.
You scan it and then it says like this was sent by Novartis on blah. So this is it. Or they will like have a code and then you call up the phone number and enter the code and then it says yes, this is Coartem, not something else. I mean it's not a perfect system because counterfeiters are very ingenious and there's a lot of incentive, and presumably you could create a fake barcode and then pay some guy to sit in an office and answer the telephone and say, yes, that's correct. And you could get around it, but it requires a little more ingenuity. Question?
I think dispatching resources in case of emergencies. So if you have an emergency situation and you need resources, just uploading the data that dispatches something.
Right, so the speed.
Yeah, speed.
Very important.
It allows low literate people, or literate or low literate, to collect the data.
For example, how? I think we talked about this demography, but what are you thinking?
I mean, from using pictures that you can scroll through, even using like voice prompts for education, or even for the data collectors, as one for this option.
Good call. Did you?
Kind of the same concept, but I was going to say it could be more culturally sensitive because you could translate it more easily and have a voice in their own language, and you can have pictures that they could culturally associate with. So you could kind of tailor it specifically to the group that you're targeting.
I like the way, like how at Demagi that they would read it in Hindi, right? You could sort of talk back before the voice would actually come on and read the questions to you in Hindi if they were literate. It's very clever. So.
Tracking supplies and keeping track of like stockouts.
Yeah, absolutely.
Like to kind of manage misinformation, like only asking questions that are pertinent to your subject, instead of having like a whole bunch of questions that like, might get filled in that aren't relevant, that you're like, what is this?
So you can sort of tailor the information, the form can become smarter.
So that it can only be collected.
Good. You definitely cannot do that with paper forms. Deborah and then Catherine will move on.
About the issue of combination of educational resources based on paper-based, sometimes you will not be procuring of paper to write or maybe like ink and all those things. So when you use an electronic database with them, actually bank-based, transparent data, the limitations are still in place.
Okay, so you're sort of anticipating my next issue, which is where does it not necessarily work? So.
Yeah, I think following off what Nicole said, if you are doing like some sort of survey and you realize you're missing a question or you should ask something a different way, you can easily change your programming and it's easier to roll out than getting people all the new paper forms.
So I guess we're hopefully we brainwashed you over the last 6 weeks to think that this is a very useful tool, and your ideas are great. So let me go through my list, and a lot of them you spotted already. So reduce cycle time from capture to analysis is key. Improve fidelity of data, and I guess I would say that the big fix here is that it eliminates conversion from paper to electronic with keypad errors. But someone also mentioned logic. So an 8-foot-tall child. Okay, so you can reject answers that are clearly wrong, built into the form, and that is very handy. This can be as simple as like if you specify in the question you want centigrade and they enter 98.6, it can kick that out and say no, please give me 36.1. So very simple logic around ranges. Or you can have really kind of complicated things like the time machine error, where you can have a logic saying this date appears to be in the future. Please enter the right date. I mean, that alone eliminates an enormous nightmare of mistakes. This one you didn't mention, but I guess it's sort of obvious that, like in the ZAMCAT study, have you guys heard of the ZAMCAT study that David and Haver are doing? Okay, so they've got 42,000 subjects, each patient contributing 90 pages of data for the primary trial, plus 36 for the WHO supplemental study. So that adds up to something like 1.7 million pages of data. And that has to be put in a big box somewhere. And not so. It's crazy. I mean, when you think about it, it's crazy. It's just like vast, the entire room of paper. And imagine like entering you're actually using teleforms, which is like a digital scanner, but still they have to feed them in one by one. It's a nightmare. So that is huge. Not having to store them. Real-time monitoring of data is important if you're trying to monitor the quality of it. I'll come back to this in a second. You can clean the data from the beginning. You can detection fraud. Now, how can you detect fraud with electronic data capture? Anybody have any thoughts on that? Fraudulent data entry. Somebody mentioned.
If you're getting blood pressures that are consistently 120 over 79 or something like that.
Funny patterns that just really can't be true.
Or like they're entering all their data at once, they should be visiting all the time, and all of a sudden they're like, oh, I didn't do my job, and I'm
Absolutely. So clustering of information. And there's another thing that Demagi was doing, right? Where you if you're a data collector.
Not Demagi.
Who was it? Neil. Neil was working on it. It should take a certain amount of time on average to fill out one of these forms. And so if they're filling it out on average 5 minutes less than anyone else, that's impossible. So you can flag like patterns that just say that this data collector is off the range. There's another way that turned out to be really important in our study, actually.
GPS.
GPS location?
Yeah, exactly. Yeah, so and precisely what we had. We had 16 data collectors, 15 lived in district and were assigned to their zones, and the 16th lived out of the district and would take the minibus in, which was like an hour and a half, and then do her work. We could never figure out how she was doing this, and as it turned out, she wasn't. She was sitting in a coffee shop in Kitway filling out all the data and making up all the information for her subjects. So with GPS, we would have spotted that instantly, because we could see that Kitway is not on the catchment zone for the study. so that is enormous asset. So those were what I thought. You got them too. Entering data on the right patient. This is a really hard one. This is a really hard one because one of the common errors that occurs with paper forms is this is subject 106 and it goes in as 109, 107. And so now that information is misattributed to someone else in the randomization scheme. So now the entire form is wrong. Even if the data was entered everywhere else correct. Subject ID wrong, that is like you've blown that entire encounter. And so it's a devastating error. So easy to do with paper forms, just to get the number wrong as you're typing in subject 106, 105. Oops, and you never catch that. Barcodes would be the simplest way. Links to GPS, so that was another thing that Demagi was working on, would be to have, like when the data collector goes out and the phone now says, I'm here. The data, the EDC says, okay, the subjects who live near here are these subjects, and therefore we're not going to accept any other subject IDs as being possible because we're in the wrong place. You know, it's sort of, you can be clever that way. So, all right, now here's some others. Case report form version control held avoided. So there's a dictum in research that like when do you have the last version of your case report form is the last subject last visit. Because you're changing them constantly, and it drives you crazy. You say, I'm never going to do that again. I'm going to make the forms right the first time. No, you never do. You're always changing them as you go through the study, and every time you now have to go out and find those data collectors and retrieve all the old forms and give them new forms, and then electronic data capture, you can push the data, the forms, to the phones and pull the old ones off simultaneously. So you can insist that everyone in your data system is using the right forms at all times. That is huge. All right. And here's one, thanks to Laura Karada, who made this table for us, is that electronic data capture can actually be cheaper. And so I'm not going to go through all the assumptions other than that a lot of the costs of paper-based system is paying the salary of the data entry clerk, who has to be paid for a long time after the study is done because of the data cleaning. So you pay this guy for the whole duration of the study, and then for a year after the study to do the data cleaning. And so that can make all the difference. Plus, paper is expensive, especially when you're doing a large trial. It's cheaper to buy 15 handheld devices than 1.5 million pages of paper. So, so the cost savings can be substantial. All right. Now, there are situations where electronic data capture is not helpful. Can you think of it? Actually not helpful at all.
It'd be less helpful if you don't have service.
Partners in Health. Could be. What else?
I know one of the things we're talking about with Pathfinder is when you capture information relating to an emergency situation or a delivery, like a mom delivering a baby. Are you going to stop her before she comes in and say, "Give me your name, give me your location, how
Right.
far along are you?"
Not helpful.
Right. So,
That's true. Not helpful. Yeah, you're right. So there it can be inappropriate.
Maybe for open-ended answers,
Yeah.
a long explanation of something is difficult to interpret.
I was thinking exactly the same thing, Emma. That qualitative research probably is better actually with paper, because there you want to have someone sort of unobtrusively taking notes and just kind of like documenting what they say. And if you're like trying to like type in on your thing, boy, you can type really fast.
No, I mean record. I was thinking not even just type.
You can record. You can record. You can record. So yes, you can do that. But the fidelity of the voice capture on the phone is often not so great.
Yeah, and people may respond differently.
And they may respond differently. So some IRBs get really snippy too about making recordings at all because they consider that to be an identifiable piece of information, the sound of your voice. So the best way is just like writing it down as freehand. So I think with particularly small qualitative research studies paper is probably better.
one of the other things we're running into is data maxes on the phone or on whatever your individual medium is. So if you have a study where you have 92,000 patients or clients or something like that, it just might not be feasible to have some kind of mHealth medium that you can use to capture that information.
Power supply would be another one, I would say. That like some of the devices are real power hogs and run out of batteries quick. And so if you've got a long form and it runs out 2/3 of the way through the form, you're like, and you may have just lost all your data. So that would be another one. At least it's a limitation. So those are good thoughts. Okay, so electronic data capture, I think, is really great in most situations. And so what I want to talk now about is research on mHealth interventions and sort of where we are with this field. And Marion McNabb from Pathfinder did a nice systematic review on this very recently, and she's provided you an executive summary. She's not going to distribute.
No,
we're going to pass
get
out.
Permission from Pathfinder.
So why don't you pass this around? It says that, I'll summarize, that there is not a lot of information about the effectiveness of mHealth interventions.
On health outcomes.
But you were much more eloquent.
On health outcomes.
And you were much more eloquent. And so what I wanted to do is talk about that, because it does seem odd that something that is so intuitively obviously useful might not be proven to be so. And why that might be. And there are many reasons, and I'm sure John Payne actually has some better answers to this. These are the ones I thought of this afternoon while I was trying to figure out what to say today. So I'll start with this. This is a graph of mortality after bite by rabid dog, before and after the introduction of Pasteur's vaccine, which occurred in July 1885. So, there was no randomized controlled trial of this vaccine. We could do one. However, it does seem intuitively obvious that the vaccine worked without a randomized controlled trial. Here's another one. Parachute used to prevent death and major trauma related to gravitational challenge and systematic review of randomized controlled trials. So there aren't actually any randomized controlled trials of parachutes. But the observational data suggests they work.
I love that. Why the study out?
But as they comment, there are some biases. There are some biases because people who jump out of planes without parachutes may be psychiatrically disturbed and have a higher risk of mortality anyway. So you can't be too sure, so maybe we need a trial. Maybe we need a trial. You never know. But here's a more serious example. This is a meta-analysis by Jane Simone from a couple of years ago, who's an AIDS researcher out at UW in Seattle, who was looking at the issue of behavioral interventions to get people to take their HIV meds. And so what you're looking at is a series of around, 15 or so studies. And the middle line is where there's no difference between the control and the intervention, okay? And, the interventions are all different kinds of interventions, but they're all aimed at the same thing, which is like, please take your meds, please take your meds, please take your meds. And some of them worked, some of them didn't work. Okay? And so, a reminder that most interventions in research don't work. Most, 90%, don't work. If they were obviously going to work, you wouldn't do the study. So most research is done because you don't know the answer, and most of them fail, by definition, and mHealth is no different. And so you would expect that, as in any field, the majority of mHealth interventions won't work because most interventions don't work, regardless of whether they're effective or not. And so that's just normal. And so the fact that we're looking at this and going, oh my God, it didn't work, should not be unique. It is just the nature of research. Mostly it doesn't work. And you keep looking.
Something else that we've talked about, I think, is that it may be wrong to think of mHealth as an intervention because it is a vehiel. It is not.
It's a vehicle. It's not an intervention. She was so disrespectful. It also is like a misapplication of it's wrong. All right. It takes time to develop evidence for a new field. So claims of supernatural powers. We are working on this. So far, it's not looking good. mHealth is not the solution for all problems. So for a fair selection, everybody has to take the same exam. Please climb the tree. Okay, so there are situations where mHealth interventions are likely to work. And sometimes it's a dog trying to climb a tree. So you can't generalize again, because as Camille says, mHealth is not an intervention. It's a platform for creating applications, and it's the application that's the question, not the platform. And so it's a very important distinction. And so if it doesn't work, well, what was it you were trying to get it to do? And maybe you asked the wrong question. Okay. And here's another, this is the last one I thought of, but I think this is important, and Wolfie and John and I were talking about this earlier, Mary were talking about this earlier. And I think this is true, which is that mHealth developers, the programming guys, are usually not public health people. They're usually not clinicians or researchers. Program implementers are often not researchers, and researchers are usually terrible program implementers, to be quite honest. Myself clearly included. I've gone on field trips with Dave Marsh to look at their work at Save the Children out in Ethiopia, and he's doing all these matrices and diagrams, and I'm like, it's like, just tell me what the damn sample size is. I have no idea what you're talking about. It's a different language. And there's an important perceptual, or I guess sort of almost philosophical difference between them. And it is neither that the one is right and the other was wrong, they are just different. And so let's sort of think about, you've all taken biostats, Epi, right? So what is the fundamental core principle of statistical analysis according to the frequentists? It's the rejection of what? Right. Which means implicitly that you are assuming it doesn't work. That is your baseline assumption. It does not work. And the whole purpose of the experiment is to reject the assumption that it doesn't work. But you're starting believing it doesn't work. That's the whole basis of science. Whereas the program people assume it does work. It's a completely different starting point, a completely different set of premises. And in an ideal world, it goes from, hypothesis tested by the researchers, reject, 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 reject. Here's one that works. Pass to the program people who then implement it. But we're looking at this process from totally different sides. And so when you have, I think, unfortunately, when research is conducted in a programmatic sense, it often tends not to generate scientifically robust results because they're not approaching this as the researchers would. And so there's a muddling of that. And I think that has created some sort of smoke around this. And so, my feeling is that we just need to give this some time. It's only been a couple of years, for goodness sake. The studies so far have been very small. Marion talks about pilotitis. It's true. When you have 200 studies with 50 subjects, you're not going to prove anything. What you need is the study with 50,000 subjects. The power for 95% confidence, with robust endpoints, powered on mortality, but those are the studies that take big bucks from the NIH and a lot of arm twisting. And that hasn't happened yet, but it will eventually.
They're ongoing right now.
Yes,
So like
will eventually.
there's a review that just came out by Alon the Brief. There's 215 clinical trials registered in the NIH database on mHealth.
Not good, Dan. And we're doing one.
215.
We're doing one.
Okay. Over 20.
So, so I wanted to do a case study with you guys. Are we okay? Good time?
7.
What do you want me to do? We can go straight to the exercise.
What do y'all want to do?
We can be quick about this. All right. So, some time ago, we were approached by a colleague, a very smart guy, who said, we have an intervention, an mHealth ComCare app, right? For identifying children with malnutrition.
We want to develop it, yeah.
Right? Yeah. Perfectly good app. We want to see if this will reduce childhood mortality in Vietnam. Good. We're going to write a grant to the NIH students. And I said, no, it won't work. It can't be done. And he was very enthusiastic, and I said, it can't be done. And I really felt bad because the guy was getting upset with me because I was so negative about this. But it can't be done. And I want to sort of think about this from the researcher's perspective and sort of have you guys brainstorm about why it is that it is so hard to actually show that this little app will save lives, even if it does. So, let's kind of create a, I call them conceptual models, you call them process maps. They're the same thing. So let's say we have this, yeah, I know, people in IH 702 are having flashbacks. You have this observation that nutrition, like bad nutrition goes to dead. Okay? That's the hypothesis. Therefore, better nutrition equals less dead. Yeah, I'm buying it. I mean, this is probably true. It's probably true. So, where can we go wrong on this in terms of like using an app to drive less dead?
Well, an app isn't actually behavior change.
Okay. All right. So there's an assumption, right? State the assumption for me, Patty.
That just because you implement an mHealth application does not mean you will change the nutritional behaviors of.
Okay, let's be even a little bit more specific. Not implementing the intervention, but the effect of the intervention will in fact change nutrition. So what changes a kid's nutrition in real life? Okay, I'm just going to say, if you identify decreased nutrition, you will increase nutrition. So what actually affects a child's nutritional status? Money. Does the app get the mom money?
No.
Okay. What else causes malnutrition? Access. Okay. Does the app give you access? No. What else?
Comorbidity.
Comorbidity. Does the app give you vitamin A and iron? No. Okay. What else? What else? What else causes? What causes low iron stores? Not having enough food. Okay. Does the app give you food? No. Okay. What else? Natural disasters. Okay, it doesn't prevent those.
That's a good idea,
I typhoon. All right.
I think it's kind of if you look at it as a confounders, you have measurable and non-measurable confounders that can change the picture.
All right. All right. So what I'm going to say is that there are lots of things that feed into this thing of nutrition, one of which is lack of information. One. Okay. But so many others that are not influenced by the app. Okay. What about dead? What causes dead kids? Nutrition one. Infection. What else?
Injuries.
Injuries. What else? Infections, we got those. Infections.
Inborn errors in metabolism.
Inborn errors of right. Bad genes. Bad genes, too. Yeah. Bad luck. This is bad luck, this is bad genes. Okay. I guess, the point is lots of stuff go into dead. And so what fraction of dead equals nutrition? Let's say it was a lot. Let's say it's 10%, which is generous. What fraction of 10% is due to lack of info? 10%. Let's give you generous. So 1%, you're pulling a lever that moves this thing by 1%. And you want to power a study with $250,000 to show that that's going to work? It won't work, even if it does.
That's the problem. One thing about mHealth is so to make it simple so it can work. Now, for this kind of implementation, we realize that having an app alone for nutritional information is not going to help. The ideal tool is to get a more comprehensive, integrated application that has so many things to deal with the whole issue. But that's itself is the complex.
That it was a decision app, not just
Yeah,
information.
and I will say that the weird thing about this is that I actually think the nutrition app is a superly good idea because it probably works. But that's not the same thing as powering a randomized controlled trial on mortality based on that. I mean, yes, you could do it, but you'd need 40,000 subjects to show that endpoint and a budget of $100 million.
Also, to what do you compare? What's your control? Are you gonna? Is the comparison no app, or is it a completely different app, or is it some
Okay, so what if
iteration
it was
of both?
app versus no app? How would you then design a study that would get around the quirky biases that might exist in that particular study?
Have people using the app, but
They'd have to be using the app like exclusively for birth, right? Like
Yeah,
it
yeah.
has to be something.
Not just one time.
All the time.
All the time, right?
I was gonna ask, can't you just measure something else like that? Like you could measure, it doesn't have to be like this, there's an intermediary.
Right.
Like food intake or weight or something.
Right, and this is sort of what we suggested, is like, let's go for something a little more like intermediate, like weight gain, or episodes of diarrhea, or something like that, or referrals completed at the clinic for malnutrition. I mean, that would be a very, very useful intermediate endpoint. Did the mom react to the information from the app and actually take the kid to the clinic for an evaluation for their malnutrition? Because if they didn't, then you can assume that it won't translate into reduced mortality. Because that's how the lever works. It's not the app, it's the behavior triggered by the app. And if she isn't doing anything, then clearly the app doesn't do anything. And you could measure that. That would be a very, very reasonable study. However, in the meta-analysis, it's going to show up as no effect on mortality like all the other studies. But obviously it's not going to work, because it can't work at that scale. It's just not the way it works. It's more complicated than that. So, I think you get the idea. So what we were going to do is to have you guys, within your groups, within your projects, within your app, try to think about what you've been doing as a research question and how you might approach that. And what some reasonable endpoints might be, and a reasonable design by which you might assess them. Okay? And as a framework, let's start by saying, how do we begin a research study? What do we need?
Research question.
Right, so question. What else? What's next? Well, you've got a question. A hypothesis, right. All right, what do you need next?
Method.
A method. And what do you need next? Well, a part of the method, what would that be? Population. Okay, so who? Where?
How many?
How? And how many? Yeah, how many? We'll kind of skip that one because that's sample size, and we don't have the bandwidth to figure that out here. But sample size, yeah. And lastly, what are you going to measure? Yeah, what's your outcome? So, with that, why don't we give you guys 15 minutes? How do you want to break the time, Marion?
Well, we can take a break and then we'll come back.
Okay, so we'll break first, and then work on this for maybe 15, 20 minutes, and then start sharing ideas around?
Mm-hmm.
What's our schedule?
Yeah, we're going to be finished at 8.
Okay, great. So that would work fine. Great?
Yep.
5 minutes.
Perfect.
Okay.
Can you give me?